Hello and welcome to Bangalore International Centre's very own podcast, BIC Talks. Bangalore International Centre is a platform for informed conversations, exchange of ideas, and a space for arts and culture. BIC Talks brings the essence of all that the physical space stands for and more to your doorstep.
The COVID-19 pandemic has always spread faster than we can test for, and it's all the more true in India. Outbreaks have spread faster than the scaling up of testing, tracing, and isolation. We've known for a while now that for every single person who's been diagnosed positive for the infection, there are several who have been infected, either with or without symptoms. Serosurveys therefore become an important tool in helping us figure out how far the infection has spread within a population. A new study on Karnataka shows that even as early as mid-August, close to half the state, about 31 million individuals, may have been infected by COVID-19. They also find that the rural spread of COVID has been almost as high as the urban spread of the infection. Hi, I'm Pavan Srinath and welcome to BIC Talks. Researchers Manoj Mohanan, Anu Acharya and Anup Malani join me today to help us understand and interpret their new study. Manoj Mohanan is with the Sanford School of Public Policy at Duke University, Anup Malani is with the University of Chicago, and Anu Acharya is the CEO of Map My Genome. They are also affiliated with the IDFC Institute and are three of the four authors of the Serosurvey of the state of Karnataka. You can read the full study from the link in the episode description. Our episode today is an edited version of a live conversation on BIC streams that took place on Tuesday, November 17th.
Since the pandemic has started, there's also been an explosion in information, and it's been like a daily or a weekly exercise in educating ourselves on virology, on statistics, on what seroprevalence means, what our serum antibodies are, and what they imply. And I think we've learned a lot in the last few months. So I'm hoping that there'll be a vibrant discussion today. I want to hand things off to Manoj. Manoj, please walk us through the study, the main findings, and how you went about looking at Karnataka's COVID-19 seroprevalence.
Thank you, Pavan. Just a sense of background. So my co-authors, Anu and Anup, were both part of this effort that the IDFC Institute had put together, and a task force to help various governments with the initial phases of the COVID response. So in that early phase, Anup, as well as Anu and I, we were all trying to understand the testing technologies and what governments were doing with different types of tests, and what we can try and understand from different types of efforts that states and central government were trying to do with testing. So it was in the context of that we quickly realized that one of the key tools that the government needs is data, which sadly at the time was not available. Data for policy making to understand the extent and scope of the infections and how fast it was spreading and where, importantly, it was spreading. Because remember, going back to even in March, India had introduced one of the strongest lockdowns, the strictest lockdowns globally, before we even knew where the epidemic was. So around May or so, Anup and I had been collaborating with the government of Bihar, and we were trying to test the migrants who were coming in using RT-PCR to understand current infections. And what we found was a surprisingly high percentage of migrants who had just come back, returning workers, I must say, not migrants, who had just come back from Bihar who were positive with infection. So this was already giving us the first sign that the infection in India was spreading quite dramatically, not just within areas, but across areas, going from urban to rural. So it was in the context of that we started a number of efforts to try and do large seroprevalence studies across the country. So the Karnataka study was part of that effort. And we started collecting data between June and mid-August of 2020. It was not easy, mainly because, lockdown was in progress, just doing basic stuff. It was hard to do your groceries. So you can imagine how hard it might have been to go out and collect data and come back. The main things that we found, if I had to summarize in a couple of sentences. One, the prevalence of COVID infections, past infections in rural areas was surprisingly high, probably almost as high as what we find in the urban areas. And our estimates for urban areas are fairly comparable across comparable to studies that have done this in other cities as well. So it's not like we are an outlier. The rural areas is actually the innovation. And the reason why we were able to do this is our partnership with our fourth co-author, who is not here on the call today, Kaushik Krishnan from the Center for Monitoring Indian Economy. Those of you who follow this might already know it, that CMIE, as part of its Consumer Pyramids household data set, conducts the world's largest household panel data surveys. They interview about 174,000 households 3 times a year for the past 6 years. So we had this really interesting sampling frame that we could borrow from CMIE and then sample households within that data set to be able to then track them. And that's what really helped us in several things. One is to be able to reach households from that are carefully selected and sampled in rural areas, and also had better buy-in to be able to access these households and do the tests. So overall, what we learned is the high rates of seroprevalence in rural areas, but also that at that time, the infections in various parts of Karnataka, especially areas like the coastal parts, as well as districts like Mysore, were going through a fairly rapid increase in the rates of infection. And that's because we were able to test them both for antibodies as well as current infections. My colleague Anu Acharya would be able to tell you a lot more about the choice of different types of tests and our decisions about what to focus on and how we implemented them. So let me hand it off to Anu to take it from here.
Thanks, Manoj. So we had decided to do actually initially 3 tests, and then we focused down on antibodies using the ELISA method and also RT-PCR. I think a lot of you would be familiar with RT-PCR, but RT-PCR is basically looking at the virus, which is about 30,000 base pairs long, and we are trying to find certain parts of it in our nasal or throat swabs, right? So you're trying to find if there is an amplification of the virus, and you're trying to find that. So that will give us an understanding of what the current infections is. So whenever somebody wants to test if they actually are COVID positive, it means that the virus is still in their body. So we definitely wanted to look at the option of finding out how many are actually currently infected. But at the same time, I think the more important data was to also find out how many were already infected. And in order to do that, we are basically looking at the most common thing that happens after you're infected. That is, your body's immune system is actually sending out the warriors, the antibodies, and that's what we are measuring. So now you can measure this by many different ways. You can measure it by many different techniques. And the one that we chose was the one that was made by the Translational Health Sciences Institute. And this was looking at a specific part of what we call as the receptor binding domain. And we tried to find that because it's one of the most sensitive tests, which basically means that you're trying to find something that will give you, when it says it's positive, they're actually true. So we were trying to find the most specific as well as the most sensitive test. And we found this test to be the most sensitive of all the other tests that were available. We also then decided to do an RT-PCR test. And the reason we chose the one that we did ultimately from BioMaru was also primarily for the same reasons. So we did both of them. And it was interesting because I think most of the surveys that we found before were either one or the other. And I think what was interesting in ours was that we could combine both. So it could sort of give us a sense of what happened in the past, but also where we are currently, so you can predict the future.
One thing I just want to clarify or just kind of characterize on Manoj's point, which is sometimes hard to think in percentages. Sometimes it's easier to think in absolute numbers. And to put in context what we're finding just in Karnataka state with what is reported nationally. And again, this is not inconsistent with any of the serological studies done, which generally tell us that there's a lot more cases. So right now, if you look, there are about 8.3 million confirmed cases India-wide. Those are just confirmed cases. Whereas what we're finding in this study with 46% seroprevalence is roughly 31.5 million people just in Karnataka by, say, end of August may have been seropositive. And so that's a 3 times multiple just in the state of Karnataka alone, which gives us a sense of why just COVID testing alone won't give us a sense of how far the epidemic has progressed.
Anup, my first question is actually to you. I want to get a sense of how various seroprevalence studies have taken place across the country till date, because I think the Karnataka studies are the most recent, with perhaps the ones in Mumbai being one of the first. And I think you and Manoj were also involved with that. So give us a sense of what the difference different sero studies were trying to focus on. Here, one of your key things that you're trying to measure is a statewide number, right? You want to get an accurate picture with some range and with some bounds as to how many people might have been infected by COVID-19 before the study date. Could you walk us through the studies that have been done so far and what we've learned from them?
I'm sure the audience has heard of most of these studies. So obviously you've mentioned the Mumbai study, which occurs in July and then once again in August. Although it was the July results, I think, that were widely reported. Shortly after the Mumbai study, there was a Pune study that was reported. After that, there was a study in 4 districts of Andhra Pradesh that were reported, both in rural and urban areas, as it turns out. And then in the background, there was a study being done by ICMR. It was actually done over some time across many districts across India. And that occurs during this time, although reported a little bit later than the Mumbai study, if I remember. And then also there are 2 studies that were done in Delhi, just like a month or so or 6 weeks or so apart, repeat cross-sectional studies. So those are the kind of the span. I hope I haven't missed anything. Obviously, we've already mentioned the Karnataka studies, both the ones that we've done, but also the one that the state did. So there have been a number. And I believe that there's one that's ongoing. I know that there's one that's ongoing in Tamil Nadu as well. And there may be others that I've missed, but this gives you a sense of the number. And this is actually remarkable because I think in India, we have many more serosurveys than many other countries that are comparable. So it's actually a testament to how quickly we've been able to act. Now, there are 3 dimensions, I think at least, that are critical for comparing or thinking about these studies. The first is when you do a survey and you want it to be representative of the population, you want to make sure that the sample you study is representative of the population that you want to talk about. And so what we want to do is compare these studies across how they selected their sample. And so I can talk a little bit about how that varies. A second dimension is the date during which you study. So we know that the pandemic rises and falls and rises. And so the prevalence that you're going to get, or the accumulated prevalence you're going to get, is going to depend on when you do the study. Earlier studies might find lower numbers than later studies. The third issue that's going to be important that Anu talked about just briefly is what tests you're going to look for. So are you going to look for actual presence of the virus, or are you going to look for antibodies, or are you going to look, for example, and this hasn't been done yet, although I think there's talk of it, look at T cell or cellular immunity. So those are the 3 dimensions that we care about. Now, the most important that I want to focus on, because I think there's nothing critical about early versus late date other than you want the latest data. What I want to focus on is the representation. So this is really hard. Having been involved with Manoj in now 2 studies, and with Anu and Manoj in advising a number of states on how to do such sort of studies, we realized the challenge is finding that representative population. And so different people do it in different ways. So sometimes what individuals do, or what studies will do, is just say, I'm going to geographically disperse my population. I'm going to sample from a number of distant districts, 30 districts, 80 districts, whatever it happens to be. But then within the districts, you have to also be very careful about how you sample. So for example, are you sampling at hospitals? Well, that would be problematic, because then you'll get an overestimate, maybe because the people that go to the hospitals might be more likely to be infected. So it's not enough to just be geographically dispersed. You got to think within those geographies, how am I going to get the right population? And even when you do the opposite, let's suppose locally you're going to be very representative, you want to be a little bit careful about who you sample. So take Pune, for example. Pune did a good job of locally being very representative, but they were looking in, I believe, 5 areas of the city that had higher rates of COVID incidence. And so you're going to get a different estimate that's appropriate for high incidence areas. What we tried to do in Mumbai, and then what we tried to do in Karnataka, is to be take very seriously that representation. So in Mumbai, what we did is we went to slums and non-slums, but we selected a lot of different areas so that it was geographically dispersed and very representative from a physical space perspective. And then within there, we did what is called systematic sampling. So we went to every 4th house, let's say, and that way we were spread around the community. In Karnataka, we did something similar, except that we already had, because of the Center for Monitoring Indian Economy's representative frame, we already had a representative sample of actual households in Karnataka. So we had that frame set. And then within those, we then asked people what to do. So that's the approach that we took, and why it's important to be careful about that when you think about any kind of conclusions that you draw from it and how representative those are.
Thank you so much, Anup. And I want to throw this to Manoj first, but please, all of you can chip in. This is perhaps the most important question to me. The number 46.7%, right? I mean, even if you take the confidence interval, that's between 43 and 50% of Karnataka. by about August, according to the study, had already been infected by COVID, like half the state's population. And we know that the RT-PCR and the individual test counts are heavy undercount, right? I mean, typically people talk about a 10 times multiplier, 20 times multiplier coming from Serosurveys, but your study has found a 96 X multiplier, right? So which is at one level alarming, at another level it feels like comfort, because okay, if that much of the infection has sort of gone through the population, then maybe we are doing better than we expected to. So can you help us make sense of that?
When you look at these numbers, you want to think about whether these numbers are likely to be biased or are they just imprecise. And the way to think about the bias, or whether we've got these numbers wrong, to put it in slightly less technical terms, is to think about how these samples were drawn. I'll give you a simple example. If I wanted to know the height of people in Karnataka, but if I had only gone out and sampled children or women or elderly or any of these groups, chances that I would get the correct number is very, very low, right? So the fact that we started with an existing frame of representative sets of households that CMI has been following, and it's not a small set, right? These are a very carefully curated set of households that give us a picture of what's happening in all of Karnataka. And within them, we are able to fairly clearly document whom we tested, whom we talked to, and who was able to participate. So it allows us to then correct for any differential participation, or the fact that, in the CMI sample, we have 41% young children versus 43% in the state. I'm just making numbers up at this point. But the idea that we have very clear information on who is being included in the study gives us a lot of confidence about whether these numbers are actually accurate or not. That's the bias question. In terms of sort of making sense of how these numbers compare, in some sense, I'm not even quite convinced right now that if you had data in August from various parts of India with comparable studies that are able to do representative populations, my guess is we'll find estimates that are fairly comparable. The problem is right now we are comparing one study that has numbers from rural India versus a whole bunch of others that have numbers from urban India, and the assumption that rural India has not had infections. We don't know that, right? If we had data from rural Maharashtra and rural UP and rural Bihar, then we might have been able to compare and say, well, this makes or does not make sense. The only number instead we have, exactly as you said, is the number of officially reported RT-PCR cases in the nationally reported numbers, which was about 8 million a couple of weeks ago even. The challenge with that is the vast majority of cases in India are asymptomatic. The early data coming from Maharashtra and Karnataka told us that about 95% of COVID cases in India were asymptomatic. Well, if it's asymptomatic, the only way I would get tested as an asymptomatic COVID patient is if my friend Anup, whom I was having drinks with last week, tested positive and he was symptomatic. And then through contact tracing, you found me, right? So the ability to get that 8 million number right depends on two factors. One is being able to find Anup first, which for reasons you just mentioned, we know that's not perfect. Anup might not want to get tested because he's worried that Anu will not talk to him after he tests positive. They might not let him go eat wonderful meals at Anu's house and so on and so forth. Or he might be worried that the state might impose quarantine, or there might be social stigma, or he might think it's not important, or maybe he can't afford it, or maybe labs are not testing. There's a vast number of reasons why you first wouldn't find Anup in the first place. Conditional on finding Anup, you need to get information about whom he hung out with, aka me, and then be able to contact trace me, find me, convince me to test in time, because there's only a short period of time in which you can test me and find me positive. So all of these factors are working against us in getting that 8 million number correct. Instead, if we had done a random representative population and tested them for RT-PCR, you would be able to extrapolate what percentage of the population in the state or the country is currently infectious. And this is where we have good news. We at least have two data points, one from our own study where we find that some parts of the state, for example, states like parts of the coastal areas or districts like Mysore, had very high rates of current positive cases in August, up to 10%, say, for example. In fact, even some of the other data coming from other sources, the state surveys and stuff, show even higher rates across the state. right? So if 10% of the population in a random sample or 12% by state estimates are currently positive, just give it 3 weeks and you will find that number doubling, tripling very quickly. Because remember, again, most of these folks are asymptomatic. If I'm asymptomatic, you invite me to your house for dinner, for a wedding, you have no idea I'm asymptomatic. I'm spreading it to everybody around. So the exponential growth is a major concern. So when you take these factors in and you think about the fact that this infection has been in India since March, we know that it was already spreading dramatically in May. By August, finding about 40%, 44% in rural areas is not that surprising. What is surprising is second part you mentioned about the lower numbers of deaths, lower rates of hospitalization than what you might have anticipated, given millions of people who are already infected. It could be a blessing in disguise. We're still trying to understand why that is the case. We are all very, very grateful and thankful for whatever reasons we've not seen those kinds of hospitalizations and deaths in India. Anup, do you have more to add to that?
No, there is one part in our study, for instance, that we take consent. And maybe there is some room for error in that thing, because some people who refuse to give a consent, I think we can't get their samples. So there is, of course, that part that we have to also consider. But other than that, I think, taking a representation across the country, I think this was probably the closest that you could get to being able to say that, are we geographically diverse? Are we making sure that we have people of all ages? Are we having people of all genders and all of that? I think that part was very well covered. And so I think this was as close as possible that you can get. Of course, if we had a much larger number of samples, it would probably get easier to understand a little bit more as well.
One specific question about Bangalore, since I'm from here and most of us who are listening in live might be from Bangalore. I found that in Bangalore urban, your sample was quite small and therefore the estimate was also wide, right? I think 30 to 80%, if I'm not mistaken. And ultimately, I think you got antibody data from about 69 people or so from Bangalore. And given that Bangalore accounts for 20% of the state's population and perhaps accounts for 30-40% of the captured infections, at least, right? Those that have been tested officially. Do you think that is a number that we can work on, given that there were other studies that you were all involved in which looked at a city specifically? And we're always concerned about population density when we're looking at an epidemic like this.
So I'll give you a quick response to that, and I'm sure Anup will have plenty to add on that as well. This is something that he's thought about a lot. So the first part is the study was designed not to tell us what the percentage of Bangalore's population is that's currently positive or previously infected. Right, that study design would have looked very different. And in fact, we are right now working on a follow-up study that will hopefully answer that exact same question. It goes back to this question of, what level of representativeness do we want? If we had got very precise numbers for Bangalore and let's say for Gulbarga, that still would not tell us what's happening in the rest of Karnataka. And so the choice we had to make was try and get a Karnataka-wide estimate, try and be able to then break it down by urban versus rural. We don't try to make inferences beyond that. I mean, everything that I tell you that things were happening in Mysore or coastal districts, that's just a trend that we are reporting, but those are not precise numbers that one would be able to hang our hats on, so to speak, from a study like this, right? So you're right. If we wanted to say something very deliberate about Bangalore, we probably need more sample sizes there. The other part is the reason why this happened, and I don't remember the exact numbers. You probably have the numbers in front of you. When we started this study, our estimates for we were going to do a lot more in Bangalore. Our target was about 500-600 households in Bangalore, which still is not huge. But the lockdowns that were imposed at that time in Bangalore were so strict that our teams had to leave overnight because, hotels were closing down. The police was not letting people walk around and stuff. So these are just the ground realities of what it was. You're right. If we were trying to say something about here is an estimate for Bangalore, this is not the way to do it. That's just to be clear, that is not what the study is trying to say.
Yeah, I mean, I think I want to stress that I know that you're in Bangalore, and Bangalore is an economically vital city for India. But it's important to remember that India has a low rate of urbanization relative to other countries, even in its own income category. And as a result, it's important to focus not just on urban areas, but also on rural areas. And there weren't a lot of surveys that were doing that. And that's the reason we made a decision very early on. We were going to try to aim at getting both urban and rural included within this study. So that's just reaffirming or giving the logic behind our decision, the decision that Manoj talked about. But the second thing I want to point out just from Manoj's comment, which is critical, is early on in a lockdown, one of the key discussions we were having is, what are essential sectors and what are not essential sectors? And given our experience in difficulty in conducting this study, even in the context of lockdown, I think an important essential sector should be information gathering. So if we want to make good policy, we should make it possible for these sort of surveys to be done. Now, obviously, the government can do these sort of surveys, but we've seen over time that in a decentralized country such as ours, states and even collaborations with the private sector or academia can help provide this information. And so I think it would be important if this were to continue or if there were another pandemic to kind of have channels for these sorts of studies to actually occur so that we're getting up-to-date data. The third thing is actually just an additional comment or addition to a point that was made earlier, the gap between what you're finding in these serological surveys and what you're finding in confirmed cases. I believe Manoj talked about that. There are ways to address this going forward in this current epidemic, as well as thinking about what we should do in future epidemic. Instead of waiting, as Anu was saying, for people to show up at the lab or for people to show up at the hospital to get tested, even for RT-PCR, one of the things that we should have as an established channel is just doing population surveys, even with RT-PCR. And then having set ahead of time a strategy, the state having a strategy for finding a representative group, maybe even drawing on existing samples or pre-preparing samples that would go out and test. I think that and doing it repeatedly would have given us a more accurate estimate. Even though the number of tests we could do is very small, we could take the total number of positives and divide by the total number of tests done. And as long as it was on a representative population, we would have been able to track what the prevalence is over time and the accumulated prior infection, I think, more accurately. So this was a good learning experience as well.
I think it would be fair to say that both in rural Karnataka and in urban Karnataka, if I were to extrapolate data from your study, by today, at least 2/3 of the population or so might be seropositive. I mean, assuming that the antibodies have stayed in their blood, right? At least I think we can say that perhaps 2/3 of the population has gotten a COVID infection since March. Now, given if we take that as a reasonably confident statement to make, what does that imply for what we're doing to manage the rest of the pandemic? And what does it imply for the economy and society in general? Is the worst behind us? So can we breathe a sigh of relief, or is that premature?
So I've been thinking about this both in two contexts. One is continued suppression, and second in the context of vaccination policy. So let's start out with suppression. One of the things that I think your question is hinting at is how close are we to something that people have talked about, which is herd immunity, where the reproductive rate of the infection begins to decline, which is a positive sign, but doesn't mean the infection's gone away. And I think the short answer to that is it's helpful for us to get some information or some conclusions about herd immunity, but not enough to know exactly when we're going to hit herd immunity. Remember, we did this estimate once. It's a population-wide estimate based upon repeated sampling within the state over the course of a 2-month period. So we want something, a little bit more accurate for a point in time in order to be able to infer anything about herd immunity. It's also the case that if you only have information on one point in time, you need to use some sort of epidemiology model to basically infer herd immunity. So it's one of those things where we want to continue looking to infer herd immunity. The one thing we can be sure is, and you're probably right, that we're a meaningful underestimate given that time has elapsed. And also we only look at antibodies and they may even decline over time, is that we may be underestimating, maybe it's 2/3. That doesn't seem completely unreasonable to me as an estimate of how many people have it. But that tells us the herd immunity threshold might be lower than that if we haven't hit a reproductive rate below 1 yet. So that's the first thing. And now the reason why that's important for suppression is because one of the things that you want to think about is you use suppression to stop the growth of the infection. That's one of the goals of suppression or lockdowns. And if we've already kind of hit that plateau, then you can actually relax suppression. If we haven't, we might want to continue doing that suppression. And obviously that'll vary depending on where we are. But right now, this tells us that there was dramatic growth despite our efforts at suppression, and that we need to kind of keep paying attention, maybe do this a little bit more to figure out if suppression needs to continue. Okay, so that's on suppression. But let me actually just add one more thing to that. There was a very interesting comment that somebody made to me recently, which is maybe we take solace and it wasn't made to me, it was actually made on Twitter. Maybe we should take solace in the idea that 2/3 of the people already have, and I don't want to pick that 2/3 number and say it's authoritative, but it's your suggestion that 2/3 of the people already have it. It suggests that in fact the returns to suppression have gone down for 2/3 of the population, which is the other complication, which is suppression is usually not specific to individuals, for a whole population. So if you're already at 2/3, and even if you're growing, one thing you have to remember is on the one hand, you're growing, so that's a reason to do suppression. But 2/3 of the people are already maybe immune, and so the benefits of suppression to them are very low. And so as you approach higher immunity levels, you might actually want to reduce the amount of suppression that you do. Okay, that's suppression. I apologize, this is taking such a long explanation, but the other part of this is vaccination. So when we finally get a vaccine, and we're getting good news, it seems every 2 weeks or so on the quality of vaccines and our ability to produce them. But when we get a vaccine, it's important for people to realize that distribution will take time. And that will mean that we have to prioritize who's going to get the vaccine first, who's going to get it second, et cetera. And a critical thing that you learn from serological studies is that there's a portion of the population that's already infected and likely very immune. For those individuals, the return to a vaccine are much lower than for people who have not been previously infected. And so one of the things that we should endeavor to do is to target our vaccination first to those individuals who have not been exposed. Now, of course, that's very difficult. We've only done a representative sample, not the population. I don't know in everybody, even in this Zoom call, who's positive, who's seropositive and who's not seropositive. So one of the things that we can do, though, is to look at different areas. And so areas that have lower exposure but high growth, those are the areas with high return, and areas with high exposure and low growth are the areas with low return. And so that's how we can start using these data, both a combination of seropositivity and RT-PCR, to actually target the vaccine across different areas.
Can I just modify that last part, Anup, you said, just to clarify? So it's exactly this data. What we mean is it's this kind of data, because the data we have today will not help us inform this decision in 6 months. Things would have changed. I mean, you're already talking about 2/3, which is considerably higher than where we left it. And who knows what things might look like in April or May, whenever that vaccine might become available for distribution in reality. So the true challenge would be for the states across India to be able to do these kinds of studies, but not just exactly as we did it, because our objective was much more narrower. They probably will want to do studies such as this at a much more granular level, so that they can say, look, here's exactly what's happening in Bangalore. This was the intuition you had. This can be inferred from our data what's happening in Bangalore. And I said, no, but states will have to do that. And they can, right? They'll be able to do this within a 2-week period, just adopting strategies such as ours, be able to collect that data and then make the strategic decision that maybe they should be doing district 1, 2, and 3 later, rather than doing districts 5, 6, and 7, that are right now at low levels of seroprevalence but high rates of infection. That's where the bang for the buck will come in.
I also want to add that I think people shouldn't infer that they can roam around without masks, because if you are in a community that hasn't been infected yet, I think even if the rest of the state of Karnataka has been in, there might be 50%. I think you should also be worried if your area or your sphere of influence hasn't had that infection yet, because it can still spread. That is one point that people should be aware of. The second is that there is also a possibility that the virus might mutate, and therefore we might see newer versions of COVID. So there are many other issues that one must also be worried about, and therefore I think people should continue to be a little bit more cautious about how they are conducting themselves in public life or when they are meeting other people.
Because of the way our family structures and community structures in India are organized, a lot of people who are elderly, who are usually at home, have not probably been infected as much as the younger population that has gone out, has been working, and so on and so forth. So if you think about, even let's say 2/3 are positive, who are the remaining 1/3 is a very important question. And if it turns out these 1/3 are overwhelmingly homebound older populations, then the chances, if tomorrow we just believe that the epidemic is over, herd immunity is here, and start going back to life as normal, as Anu cautioned us not to do, then that 1/3 is at risk of getting infected, and the chances of complications and mortality might be much higher there. So we should continue to wear masks, socially distance, physical distance, and wash hands. I cannot overstate the importance of doing that, even at this point.
But because it's such an important message, I'm going to say one more thing for why that should continue. A vaccine might be around the corner. So we're not talking about lockdowns that are endless. What we're talking about is taking personal precautions until a vaccine is here. So we just need to hold out for a little bit longer. And even simple procedures like masks make a huge difference, and avoiding unnecessary gatherings.
I think the antibody test coming positive is not the same as us having neutralizing immunity for the virus. And that is something only a vaccine can confer to us, right? Now, from data so far, reinfection rates in the short term for someone who is seropositive is low. And declining antibody counts does not mean that your immunity has gone away. There was this idea early in the course of the pandemic worldwide that you could have something like an immunity passport, right? So if you go for this COVID Kavach test, get your IgG positive for COVID-19, you're immune, so you can travel safely, and you are also less likely to be a carrier who will infect other people, even if you're asymptomatic. I think it's far too early to have that conversation yet, right? I mean, the science is not there yet. So a large scale lockdown at this level with this data does not seem to make too much sense, because the spread is already in large places and the harm might be greater than the benefit. Two, in your study, you talk about the continued need for testing. Now, I'm a little concerned and curious about that, because if the real infection rate is 100 times that of what is being detected, is there a point to more individual testing? How should we be viewing that?
I live in a family where I have 4 people above the age of 70, right? And because I run a COVID lab and others, I've been not staying at home. But one of the things that one has to be very careful about is that your testing is not only for you. It is for the people that you interact with. So I think that's one of the most important, messages that I want to tell people, is that whenever they are asymptomatic, it's possible that they got infected, but it's not about what they did to themselves. It's also about what they did to 10 other people or 15 other people they interacted with. And therefore, there is a need to test and make sure that, those are isolated. For instance, I think when we look at offices, when they're opening up, you're looking at large number of people coming into work in close, relatively closer contact with each other. And therefore, there is a need to, for instance, test over there and make sure that you isolate people who might be infected. But if you can restrict them for 2 weeks, I think you have stopped a much larger number of other people from getting infected. So I think maybe people think that because so many people have not had a problem, it doesn't mean that you won't be a statistic. There are lots of instances of cases where your own genetics might be such that maybe a normal 30-year-old will not have a problem, but so from a probability point, you have a lower chance of getting it. But there is still a possibility that you might have a very adverse reaction to the virus. We've seen lots of instances of where very young people have died. So I think that's the thing that one has to be careful about, that yes, the good news is that large majority have not had a big problem. A large majority of our age group might not have had a problem, but there is still a possibility that one, you are passing it on to other vulnerable groups. And the second is that you can also be one of those statistical figures that you don't want.
You are correct. We do not know how long immunity lasts when you've been previously exposed to COVID, although the data coming out to me seem quite positive that as far as we know so far, like looking at the duration of the epidemic, it does seem to confer robust immunity, that the incidence of reinfection is relatively low. But of course, we haven't seen the long-term effects. But the critical thing we want to point out is it's not obvious that the immunity that you would get for vaccine would be different than, either greater or less than, the immunity that you would get from actual exposure. Both those elements require leveraging your own immune system and triggering it in order to stop the future infection. And so in that sense, they both have a very similar mechanism. And in general, we don't know which one is broader or narrower in terms of the immunity conferred. So this important thing for people to keep in mind.
Thank you so much, Anup, Manoj, and Anu, for this fascinating conversation. And I must say that I really enjoyed reading the paper also because of how transparent you are with the survey methodology, who responded to what kind of samples. Often we see some of these reports coming out, but you have very little sense of what went into the study. And thank you for making this abundantly clear and easy for anyone to sort of verify or examine the study as well. My closing question or point to all of you: if there was just one thing you wanted people to walk away from, they forgot everything else about your study, but you wanted one message from your study that you wanted it to stay with people, what would that be for each of you?
That it's good news, but you still have to wear a mask.
All right. Manoj?
What she said.
I'll say something different, but it's not going to be as important as what Anu said or what Manoj said, which is we can do these surveys. They're not tremendously expensive, and we should continue doing these surveys if we want our policies to be the most informed and the most helpful.
Thank you.
Completely agree.
Thank you for listening in till the end. Please share this episode with a friend on social media, WhatsApp, or anywhere else. It would mean the world to us. And in case you're listening via iTunes or Apple Podcasts, please leave us a rating and a review. Subscribe to BIC Talks on email or your favorite podcast app, and don't miss out on future episodes. This episode of BIC Talks has Gaurav Krishna as our sound engineer, with support from S. Sarvanaraj and Lekha Naidu. And the accompanying episode artwork was made by Chandni Venkataraman.
Thank you for listening to this episode of BIC Talks. This podcast can be accessed on our website, bangaloreinternationalcentre.org, as well as on any of your favorite podcast platforms. Tune in for new episodes every week, and do subscribe to our YouTube channel and follow our Facebook, Twitter, and Instagram pages to stay informed on our latest updates.